Clickety click. Can you see me?
Perfect.
Okay, well, it's 11:40 on the 16th of March. So we are going to begin our webinar, Breast Medicine Now, with Pink Ribbon. This event is being organised by Pink Ribbon Europe, and we have the support of Pfizer on board. Pink Ribbon Europe is located, headquartered in Prague in the Czech Republic, which is a hotbed of philosophical discourse and inquiry. So I'm going to kick this off with a philosophical question, which is, why are we here? What are we trying to get out of today's event? And I think really we just want to take stock of where we are, 2 years after lockdown and restrictions and all the rest of it, given what's happened in the last 2 years. We want to try and see how precisely breast medicine has been impacted, and how do we begin to make good, if we have to make good, what are the problems, and how can we begin to get things back on track. We have a specific focus, which is looking at policy and priority. So our specialism within Pink Ribbon International is to analyse things from a policy point of view and to put the appropriate pressure on government, policy makers and implementers to move things in the right direction and to do the best that we possibly can, taking soundings and listening to what patients and people are saying to us, and blending, merging that with the expertise that comes from the medical profession to try to really inform policy. What's our geographical range, our geographical focus? As I just said, Devin, technically this event is a Pink Ribbon Europe event. I'm based myself in the UK at the moment. So we're starting that as an initial geographical focus for today's session. But obviously Pink Ribbon is an international campaign. Breast cancer is a global issue. So we're reaching out beyond Britain and Europe to further afield. We also have, as well as contributions from Britain and Europe today, we also have contributions from places like Africa and America. And the idea is to begin that program of activity, lobbying and campaigning worldwide. The specific outcome from this event, we want to create a report called Breast Medicine Now, which we can hopefully finish in the next 2 or 3 weeks. And that can be a starting point for policy, lobbying and advocacy. So we need your views, whether you get a chance to speak today or subsequently. Please get involved, give us your input and help us to steer our global program now for breast cancer prevention and cure. So we have an excellent range of discussion points. We've tried to create quite a varied spread in what we're talking about. So we're going to to start off with some initial points about figures and statistics to do with screening and referrals. I mean, I think it might be a little bit too early to come up with a completely exhaustive and conclusive summary of where we are now. The situation obviously has been fast moving and fast changing, but at least we can start to put a marker down as to where things are. As I've just mentioned, we have a range of perspectives from around the world. I think that the biggest question for us to address is where do we target efforts now? I mean, my opinion, for what it's worth, is that the biggest challenge in breast cancer, it should be directed towards metastatic breast cancer and finding a cure for that. And it's still something of a scandal, I think, that we haven't made too much progress in that area. I know everyone's absolutely trying their best. I'm getting a little bit of feedback here, and all of a sudden, I'm not sure why.
I think that the biggest question for us to address.
I can sort of hear myself, but I'm just going to carry on. We have a very interesting section towards the end on terminology and the use of palliative terminology in breast medicine, and sometimes getting the terminology right can make a significant contribution to getting the end result right. And we do want to end on a note of optimism and positivity moving forward. Just very briefly, we did a survey just before the webinar to attendees to ask, what are your biggest concerns? And why are you here? Why are you attending this webinar? I think funds and delays in research came out as the biggest concern. Obviously, the number of variants, COVID-related variants, that's been a concern to people. It seems to be like an ever-changing situation that we've been facing. And the wish list for today's event is to learn about the latest treatments and ways forward. There was an interesting suggestion from one of the attendees that we can start to create globalized standards in breast medicine. If that's achievable, I think that would be fantastic. But that is a difficult, big ask, but we're going to try anyway. And I know at least one of the attendees today has just recently been diagnosed, and that's the reason for attending as well. We have a range of questions and answers already submitted for the event, and Dr. Kath, our fantastic chair, is going to field those as we go out throughout the day. Just a quick word about the Pink Ribbon charity. It's an international organisation that is evolving from its origins. It was launched, the Pink Ribbon rather, was launched as a magazine in Britain and America in 1999. It is a work in progress to create this genuine global organisation that would be headquartered in New York. It has been set up there already, and we've during the sort of lockdown times, COVID times, we've set up Pink Ribbon Europe in Prague to begin European efforts. We really do believe, or I do anyway, in the power of a global organisation. I think it would be fantastic once this organisation is finally in place to help link up and join the dots and best practice and networking internationally. And we are also developing a Pink Ribbon Awards scheme to recognise the achievements that we are being made. So I've got one sort of final special request for the attendees. If you can just sort of say who you are and where you're from. If you can do that on the right hand side, I think there's a strip there on the right hand side. So if you can do that when you get a chance, it just gives us a really good idea of where attendees are coming from geographically today. Sorry for the slight slip there. Those are my details. You've got the website address, pinkribbon.co at the bottom. I hope you've found the session enjoyable, and without any further ado, I'm going to hand over hopefully to Dr. Kath, who will introduce herself and help steer throughout the day. Kath.
Thank you, Gerard. Thanks very much. For those who don't know me, my name is Kathleen Thompson, for the purpose of this. I'm a doctor, a paediatrician, and more recently, I work in medical research. And I had breast cancer myself a few years ago. And despite being a doctor and having all those advantages, I still struggled a lot, grappling with the system, finding people weren't always doing what I felt they should be doing and not knowing how to get them to do it effectively. Plus being in a state of shock. So I felt there's a huge need for a book to help people. And so I wrote one from both ends of the stethoscope, Getting Through Breast Cancer by a Doctor Who Knows, which really goes through how to deal with the diagnosis, the treatment. It explains what cancer is. It tells you what to do if you feel medical staff are not listening. It also explains research and the pitfalls, so it helps you understand articles in newspapers and that kind of thing. And it also talks about diet and lifestyle changes. So that's enough about me, but just to orientate you. Now, Gerard's just explained very nicely and in detail all about the conference, so I won't repeat that in the interest of time. So I'll go straight to the ground rules. I'm sure a lot of you are familiar with Zoom talks, but you'll be on mute during the talks, but we may ask you to unmute yourself when the speaker's responding to your question. We've already received some questions, as Gerard mentioned, but if you have any more questions during the talk, if you can write them in the chat, and then I'll be looking at those, and then when it comes to questions and answers, I'll bring up as many of the questions for the speaker as I possibly can. It's a very tight schedule. We've got some brilliant speakers today from all around the world. So it's really important we do keep on schedule. So forgive me in advance if I have to quickly close anybody out. So I'm not going to say any more. I'm going to start with the first talk, which we're very lucky to have Geraldine Mitchell, who is a consultant breast surgeon from Liverpool, Royal Liverpool. And she's going to talk about the experiences from the Royal Liverpool, screening levels, delays, and the worried well, some practical advice. So hopefully this will be of great interest to anyone suffering going through breast cancer at the moment. Thanks, Geraldine.
So Kathleen, I'm going to try and share my screen. I can't see my presentation, which is great. I may need your help already, Anna, to share the pink ribbon one, because
All right.
I've
Yeah.
got two presentations. Yeah, if you share the pink ribbon one, and then I can share the well-being one.
Yeah, sure. I see that someone has raised their hand. Gina, I think so. While I'm sharing the screen, perhaps. So I wonder if it's a question or an accident.
Gina, did you want to ask me a question before I start?
No. Okay.
So just to let you know who I am, I'm Geraldine Mitchell, as Kathleen said. I'm a consultant breast surgeon in Liverpool University Hospital Trust. We've recently had a merger across the city, but I'm also the co-chair of Cheshire and Merseyside Cancer Alliance. You can go to the next slide, Anna. And actually it's Steve who's done these slides for me. What we've been very aware of through COVID is the fear. What happens? What are we going to do? We don't really know what we're doing. That's medicine and patients alike. But what happens now is what I've been asked to talk to you about. We know that we never stopped treating breast cancer. All through the COVID pandemic, we continued to do surgery, we continued to give chemotherapy, we continued to give radiotherapy. What we did notice though was how we did that. We became, in my view, better because we did patient-directed treatments, which were specific for that patient based on their comorbidities, their risks, the perceived risk from COVID, and their type of cancer. As you can see, there was a huge dip after COVID was announced, and we stopped screening. Patients stopped coming into us because obviously they weren't seeing their GPs, they weren't coming in. But what's happened post-COVID, or as we recover, we have had a huge influx of GP urgent suspected cancer referrals. And probably people don't realise, but any cancer referral in the UK is sent as a 2-week, whether it's urgent or non-urgent. So that's a huge number of patients that are coming through our doors. And certainly in the Royal Liverpool Hospital, that's 6,000 a year. So it's a lot of patients. And we've noticed that it's 15% higher in last year than it was pre-pandemic. You can go to the next slide, Anna. But we've also been really, really good at getting our first treatments in. Of course, there was a dip early on in the pandemic. That's what we would expect. But we have tried really, really hard, and we've continued to do our surgeries, as I said, and our treatments. As I said, the treatments became more tailored, and we did use more neoadjuvant treatments, neoadjuvant chemotherapy and neoadjuvant hormonal blockade, reducing the size of the cancer and ensuring that patient got timely and systemic treatment. You can go on to the next slide, Anna. And we were very much afraid that we'd see patients presenting much, much later. And anecdotally, we do feel that we're seeing more patients with fungating cancers or later diagnosis, evidence of lymph node metastasis at diagnosis. But actually, that hasn't been borne out in the figures that we collect. We have seen a reduction, obviously, in stage 1 and stage 2 because screening was paused for that time. But we haven't seen a huge increase in stage 3 and stage 4. Next slide, Anna. And unfortunately, due to COVID sickness, due to staff wear out, due to national and international shortage of staff, Particularly just prior to Christmas, we had a huge dip in being able to deliver that 14-day target. Combination of things, we've just been trying to catch up with our symptomatic service, and we're trying to catch up with our screening service. And we did, in Cheshire Merseyside, we saw a huge dip towards the end of last year. Go on to the next slide, Anna. So screening, nationally, it was never paused, it was never stopped. There were decisions taken locally to pause screening. But now there is some national non-recurring funding to help us support the restoration plan to return to the 36-month round length. So as you know, all patients are screened every 3 years, and we would have an expectation that 70% of our population would be screened. But in many areas, and certainly in Liverpool, in a central city centre area, we do struggle to get to that 70%. Now we have a national shortage of radiologists and mammographers, and that's making it quite difficult. Our staff are working almost around the clock, Saturdays and sometimes Sundays, to try and get rid of that backlog. That backlog for Cheshire and Merseyside in November was 32,000. Locally, currently, we have a backlog of 4,550. And currently, our uptake is only 64%. I'll try and share the other one, Anna, if it'll allow me. So that's where we are now. So what am I doing about it, or how do I make this better? Just trying to. Can you see that? Anna, can you see my?
Yeah, all good. Yes.
I'll just run down the side actually. So what we've been trying to do locally is try to make people aware that we absolutely understand that having a breast symptom is really, really scary, and patients do have breast symptoms and patients do have breast pain. And what we have noticed in the pandemic is that patients have been immobile. We've not been able to go out. We've not known what's happening next. So people are scared. And we're trying to educate and empower patients to do the right thing. So knowing you, looking after you, to protect you has been our strapline. So knowing you, are you confident that you know what's normal, what's right? Looking after you, are you your ideal body weight? Are you eating healthily? Are you exercising? We've seen that patients' BMIs has increased in COVID. We're less mobile, we haven't been going out. We've been, I suppose, taking care of ourselves. We're trying to protect ourselves. But that's meant that we haven't been wearing a supportive bra, we've put on weight, our body habitus has changed, and we've become more aware of our body. But have we become aware in the right way? Helping you absolutely helps us. So knowing you, be breast and body aware, know what's normal, know how and when to examine. So the breast it's complex, it's response to hormones. It's not only just on the front of the chest. I say to the medical students, it's not a tennis ball that we cut in half. It extends up towards the armpit, drains into the axillary lymph nodes, but also the nodes in the neck. And it's made up principally of glandular tissue and fatty tissue. So it's going to change with weight gain. It's going to change with hormonal change. Most of that change is normal. So when to examine and how to do it properly, do you know what? You do know you best. And I think we've been very paternalistic in medicine to say, oh, actually, I'm the only one that can examine your breast because I do it all the time and I know what they're like. You wash, you're in the shower, you're in the bath, you have a feel, and we ask you to be more aware of you doing that. So look in a mirror, hands above your head, hands on your hips, look at what your nipple height is. Most patients, the breasts are not exactly the same, they are slightly different. So it's getting to know what's normal for you. Examine in the shower or in the bath, some soap on your hand or with some moisturizing cream when you're lying down. It doesn't matter how you do it, as long as you do it the same way around and circles out radially or up and down. It doesn't matter. And examine in the armpit and the neck, just so that you're aware. I think it's really important to keep that skin in good condition, and doing that makes you more aware of your own body and of your own breasts. So when should we do it? Well, our strapline has been, think for a second, for all of breast awareness, could this be normal? But think for a second, think the second of the month, anyone who's postmenopausal, examine the breasts. or the second week after your period, because we know your breasts are going to respond as you're having normal periods. They're probably at their most premenstrual, excitable form before your period, and we know that. But think normal breast change. It responds to hormones, it responds to weight, it responds to age, it responds to gravity. All breasts will go down with time, and no two breasts are the same. And these are normal breasts. I mean, you'll say, oh, well, those ones on the side, they look really, really big. On the NHS, we don't usually provide cosmetic procedures. So small breasts, big breasts, they come in all shapes and sizes. They're not always the same. And don't forget men. Man boobs respond again to hormones, respond again to weight. And it can cause a lot of distress and anxiety, not only for females, but for men as well. So what are your true risk factors? Well, your biggest risk factors of developing a breast cancer are being female and getting older. They're not easy to change, but prolonged estrogen exposure, HRT, the pill, family history. But don't forget, breast cancer is really, really common. 1 in 8 of us is going to develop a breast cancer, but it tends to be a cancer of older age. Excess weight gain and how we manage our fat also has an effect on our estrogen. Alcohol intake has been shown to affect it, and a gene defect. But gene defects are a small proportion of the breast cancers that I see, a very, very small proportion. So how do you look after you? Be aware. Know what's normal for you. Try and be that ideal body weight for so many reasons, for your joints, for your hearts, for your general well-being, for your psychological well-being. Take regular exercise. Patients who are under breast cancer treatment, we've probably been the meanest we've ever been. We've said, do not have that extra cake and sit down and feel sorry for yourself. Get up and exercise, because we know that makes a difference. We know that makes a difference in your recovery and getting back to the new normal for you. And attend screening. Like I said, we're only 64% in our local area. We're trying to encourage it. It's there. After the age of 70, you can attend yourself. You just have to phone your local breast screening program. Seek GP assessment for something that's persistent. The breasts normally change. They normally change in response, as we said, to your hormones, to weight. When they're not supported, they're going to be painful. We're interested in something that's persistent. Absolutely, we would like to see all breast cancers early, but absolutely, we would like to give more care and attention to the people that need it. And we understand there are a large number of worried well, and we're trying really hard to reassure you. But something that's persistent, we absolutely want to see you. Something that changes the shape, deforms the breast, spontaneous discharge. If we look hard enough for discharge, I will find it. It's normal. It's like your skin's looking off, the inside of your ducts do the same. So don't look for it. I'm worried about bloody discharge or copious spontaneous discharge. Try and look, be aware of what you put in your body. Reduce your alcohol intake and stop smoking. Smoking hasn't a true association with breast cancer, but we're seeing increasing numbers of young girls smoking, and the impact on your well-being and lung cancer is huge. So help us. Think for a second. Is this normal? Could it be a normal? Be aware and be responsible. These are the worrying signs, like I said, something that's persistent. It's quite normal to have nodular glandular tissue. I showed you the picture in the beginning. It's nodular glandular tissue is normal breast tissue surrounded by fat. But something that dimples or deforms the skin, something that changes the color or the texture. Nipple eczema is really, really common. If you have eczema somewhere else, it's probably going to be eczema on the breast. I'm worried if it involves the nipple papilla. I'm worried about bloody discharge or copious discharge. And go back to the fact that the majority of our breast cancers occur in postmenopausal women. It's highly unusual to see a breast cancer. It's not impossible, but very unusual to see it in a patient less than 40. And we need to be getting that message out there. And yes, something that isn't right, we do need to see it. And this is what we do. We do triple assessment. This is our unit. You get a history and examination, you get radiology if you need it, but not all patients patients who come to us need radiology. If there's something specific, we will biopsy it. Pain and discomfort, it's real, but we manage it completely differently to the way we manage period pain. And this is hormonal response. It's a normal hormonal response. We'd recommend anti-inflammatory gel. If you are not wearing a supportive bra, those breasts are not going to be supported, and they're going to be annoyed about that. They're, you know, hanging on your chest wall and they've got no support. So good supportive carrot size bra. Little evidence for even in primrose oil, but some patients find it of benefit, reducing your caffeine and being your ideal weight. Lots of us have seen an increase in our dress size, or someone's been into our wardrobes and shrunk all those clothes in COVID, and we need to be aware and honest about that. It is common. Breast cancer is very common, 1 in 8 women, but like I said, postmenopausal women, let's not forget the men. They're usually present late, to be honest. Early diagnosis, early treatment, but we're more aware of treatment de-escalation. Let's not do something that may cause you harm later on. Let's give a specific, specified treatment for you, your comorbid history, and your breast cancer. We've used more genomic tests in COVID, and we've given much less chemotherapy. And there are lots of people out there to help you, to help us. Any questions? Send everyone to silence.
Thank you very much, Geraldine. I mean, I think that was just an excellent talk, and really helping people know what to look for, and B, how to, you know, help themselves as well. Just to repeat one of the questions that's come up, which I see Anna's already replied to, we are recording this, and the recording will be available and be sent to people. So thanks for that question. I haven't seen any other questions on chat. Please do put some up if you have any. Otherwise, I'm going to ask a question which has been asked in advance about dense breast tissue and mammography. There's been a lot of talk about this and whether other scans are more appropriate, and what should be offered and what is offered in the UK. And I wonder if, Geraldine, you could comment on that.
So I showed that picture, Kathleen, of triple assessment. Our triple assessment has changed, even in my lifetime as a consultant. We now have breast tomography, which in essence is like a CT of the breast. It's multiple mammograms and all put together, and they can give us more information. And our aim is that it will give us more definite diagnosis and hopefully avoid unnecessary biopsy, because a lot of the biopsies we do are benign. Mammogram, as you know, is not great in dense breasts because they're white on X-ray. It shows up as white. So they're not routinely used in the younger patient. That's why we screen 50 to 70, because as you get older, your glandular tissue is reduced and replaced by fat. So it's much easier to see if there's a change within the breast. If we know that we're worried about something in particular in a younger breast, so say a patient has a gene defect and is on our surveillance, they will get MRIs. So they're available on the NHS. Mammograms, tomosynthesis, MRIs. Ultrasound scan is a very good test for measuring, for locating abnormalities, for helping us biopsy things. It's not a good screening, and it's not a good surveillance tool. Thermography, there's no evidence for it, so I certainly wouldn't encourage people to use it. But remember that breast cancer, the commonest age group is as we get older, and mammogram is perfect for that age group. But when we do assess the breast, if we're worried about something, if we're worried about a specific breast cancer, sometimes lobular cancers can be multifocal or bilateral, we will do an MRI. And that's discussed and appropriately decided for that patient in a multidisciplinary team setting.
Thanks very much.
Question.
Yeah, that's great. And I'm seeing a few comments are coming in rather than questions, which is great. So I would encourage people to look at the chats because I don't have time to read them out. There is one question from Gerard about the shortage of staff such as radiographers, and what do you envisage is the way to deal with that?
So we're a victim of our own success, actually, because if you think about the screening program, Forest started up around 30 years ago, and that initial group of people are now all coming to retirement. So, and we've become bigger and better, and, you know, we've done extended programs, we do surveillance. So we haven't just expanded as much as we should. There are drives. It's a lovely job. They're extremely skilled. Lots of our practitioners now do biopsies, do our mammographic reading, but it is difficult to get people into the profession, to get them into radiology and radiographers. We are trying and always trying to increase our numbers, and certainly in our unit, we only have female mammographers because we believe that that's appropriate for our patients attending screening. Do we have male radiologists? We do, absolutely we do. But it's a difficult one. Even internationally, it's very, very difficult to have breast radiologists. And we have become so specialized in medicine. We know more and more about less and less. And we want those people who have that interest and that drive. And sometimes they can be difficult to get.
Thanks, Geraldine. I think just one more question in the interest of time. We've got a couple of comments rather than questions from Joe Taylor, who's going to be talking later today. And it's very much relating to the role of exercise and lifestyle in not just breast cancer prevention, but to help with secondary breast cancer as well. Do you have any comments on that, please?
Absolutely. And we, as I said, we've probably been more aggressive than we've ever been, because we know that we make estrogen in our fat. It's one of the ways we treat our breast cancer aromatase inhibitors, or treat or offer people adjuvant treatments. So we do have to have responsibility for ourselves, what we put into our body, how we manage our body, how we exercise. And it definitely has an impact on your well-being and your impact on what you need from the NHS. And I think we do shy away from it, but we all want excellent care. And I'm not saying you should have to work for that, but I am asking that you help us out with that.
Thank you very much, Geraldine. Well, I found that a really important talk, actually, and it's great that it's going to be available.
Yeah.